Jen from we co-chaired the quality of care subgroup at the Child Health Task Force. The next one, please. The task force is a global coalition of implementing organizations, NGOs, academic institutions, UN multilaterals and bilateral agencies and country partners, and individuals working together to support the delivery of high quality of child health services. We convene and coordinate stakeholders to share knowledge and innovative solutions to programmatic issues. We develop new and improve existing tools, and we work with country partners to translate evidence into stronger child health programs, enabling children to survive and thrive. On this topic, on the webinar, we will look at the lessons from a review of programs to improve health worker performance and Malawi country experience. Yes. Can we pass the next one, Sita? Yes. And no, I think the previous one, sorry. As we all know, improving health worker performance in low and middle income countries remains a major challenge. Today, we will have two great presenters. Dr. Alex Rowe will cover the findings from a systematic review on the effectiveness of interventions to improve health worker performance in low and middle income countries. But we will also have a country experience. Dr. Owen Musopoli from the Ministry of Health Malawi will share the country experience and learning to support improvement of health worker performance and tools developed to assess health worker performance. But first, let me hand over to Mr. Martin Olsten, Technical Officer at the Department of Maternal, Child and Adolescent Health and Aging in WHO Geneva, to introduce the work of the Quality of Care Network and introduce the speakers, as we are co-hosting this webinar. Thank you. Over to you, Martin.
Thank you very much, Talia, for that. So just a brief introduction on the work of the Quality of Care Network. So the Network for Improving Quality of Care for Maternal, Newborn and Child Health was launched in 2017 in a selected number of countries with the aim to halve maternal and newborn mortality in participating learning facilities in the network countries by the end of 2022. Now, the principle are that countries learn with and from each other about how to strengthen the health system so that efforts to improve quality of care in the areas of MNCH could be reliably implemented, sustained, and scaled up through national systems. Now, the network operates in relation to its 4 strategic objectives, which you can see, which is leadership, action, learning, and accountability. And it operates with the principles of country ownership, leadership, and with a focus on improving quality of care for MSH through strengthening the overall quality of care response. And just to mention that last month, a report was launched which highlights the evolution, implementation, and progress of the network since the launch in 2017, which I'll encourage you all to take a look at for further information. So next slide, please. Now, let me introduce to you the speakers of today's webinar. So first up, I would like to introduce Dr. Owen Musopoli, who is the Deputy Director of Quality Management in the Ministry of Health in Malawi, where he heads the Quality Improvement Division of the Quality Management Directorate that leads the quality improvement activities in the country using Malawi's model of quality improvements. The division is involved in capacity building, assessment, and mentorship of healthcare workers and health managers. In his work, he works closely with UN organizations like WHO, UNICEF, and UNFPA, but also with other local organizations to promote improvements in the delivery of quality healthcare in Malawi. And we also have with us Dr. Alex Rowe, who works at the Global Fund to fight AIDS, tuberculosis, and malaria as a senior specialist in the resilient and sustainable systems for health team. He's leading efforts on improving health worker performance and quality of health services. He's also a guest researcher at the US Center for Disease Control and Prevention. He has an MD from Cornell University and an MPH from Emory University. He worked as an epidemiologist at the CDC from 1994 to 2020 in several areas, including non-communicable diseases, childhood, and malaria. And for more than 2 decades, his career has focused on improving health worker performance in low and middle income countries. And he was also a commissioner for the Lancet Global Health Commission on high quality health systems. And along with that, he's also an author or co-author of 80 scientific publications. So with that, I would like to hand over to Dr. Alex Rowe.
Hello, everyone. Just getting my slides up. Can you see my slides?
Yes. Yes.
Excellent. Thanks so much. It's a real pleasure to be presenting to you on the effectiveness of interventions to improve health worker performance in low and middle income countries, a systematic review. So let's start with, what do we mean by quality? I think there are a lot of important perspectives, as you can see here. But for this presentation, I'd really like to focus on healthcare quality, specifically in terms of health worker practices. For example, patient assessment, diagnosis, treatment, counseling, and so forth. In other words, high quality services are those that are safe, effective, and patient-centered. Well, why focus on this? Healthcare quality and health worker practices are correlated with health outcomes, which is really what we're trying to improve. Also, these kinds of outcomes are the easiest to understand and where most of the evidence is. So, why quality matters? High quality is needed for country programs to have impact. And as has been stated, poor quality is a big problem and a big challenge in low and middle income countries. Typically, only half of patients receive needed treatments. There's a high burden in terms of morbidity, mortality, and lost productivity. And it's something we can do something about. And really, that's what this presentation is on. And lastly, I think there's some important efficiency issues. So poor quality is fundamentally wasteful in terms of medicines, diagnostics, and out-of-pocket expenses. So a word on how this presentation sort of fits into the larger picture. So to improve quality of care, WHO encourages countries to develop a national quality policy and strategy. And on the right side of this slide, you can see the 8 elements of such a strategy. And on the bottom row in red, you can see one of the elements is improvement methods and interventions. So the choice of intervention should be based on global evidence, among other factors. And so this presentation summarizes the global evidence on the effectiveness of interventions to improve quality of care. The evidence source is a systematic review, the Healthcare Provider Performance Review. And it's a review of the effect of pretty much any intervention to improve health worker performance in a low or middle income country setting. And on the right, you can see a Lancet Global Health publication from 2018, which has many of the results that I'll be presenting. So we defined health workers quite broadly as facility or community-based health workers, as well as pharmacists, shopkeepers who sell drugs, and health workers in the private sector. We generally used Cochrane methods, and so our eligible study designs included controlled trials and interrupted time series. The literature search involved screening over 216,000 citations, and we have studies from the 1960s to 2016, although the large majority of studies come from the year 2000 and later. And overall, the review includes more than 700 studies on more than 100 strategies. So for example, this Lancet Global Health paper summarizes the results of the effectiveness of 118 strategies. So in a sense, it's packaging 118 systematic reviews together. The review covers a lot of outcomes, but today I'm going to focus on health worker practices. So a typical outcome might be the percent of patients correctly treated. Effect sizes have been calculated in terms of an absolute percentage point change. So for example, a 10 percentage point improvement. So what does this mean? A typical baseline performance level might be around 40%, so 40% of patients treated correctly. And then the intervention leads to a 10 percentage point improvement. And so the follow-up value would just be the sum of these two, or a performance level of 50%. This effect size also would mean that the intervention improves quality for 1 out of every 10 patients, just another interpretation of the same effect size. So the analyses in this presentation included nearly 400 studies with at least one health worker practice outcome, which represented a wide range of contexts in 64 countries. 59% of studies had a high risk of bias, so it's important to keep that in mind when interpreting the results. And the studies were often short, with 2/3 of studies having a follow-up time less than 10 months. The interventions aim to improve quality for a variety of health conditions and for all ages. Although I guess if you're defining children as 0 through 19 years, many of the studies certainly did include children. Okay, so let's move on to the effectiveness of interventions to improve the practices of professional health workers. And by that, I generally mean facility-based health workers such as physicians, nurses, and midwives. So let's start with a few general findings. So the mean baseline performance level was 40%. So kind of picture in your mind a clinic, patients are coming in to be seen, health workers are taking care of them. So on average, regardless of what the investigators implemented, on average, before they did so, only about 40% of patients were getting what they needed. Among the 101 interventions in this part of the analysis, the mean improvement was 12 percentage points. Well, let's put those two pieces of information together. With a typical scenario, you had a baseline performance level of 40%. A typical intervention improved performance by 12 percentage points. And so a typical follow-up value might be around 52%. So the sum of these two. This is actually a very important point, because what it's telling us is that even after investigators who often have additional resources and expertise, even after they implemented something, there was usually a lot of room to improve. And this is a point I'll come back to later. Most of the interventions, 80%, were tested by just 1 or 2 studies each. And so, clearly the generalizability is going to be very limited, right? If it's just 1 study, 2 studies. So this presentation focuses on interventions tested by at least 3 studies. Another general point is that effect sizes varied widely for most interventions. So take the example of training as a sole intervention. There were 78 studies of that, and the median effect size was 10 percentage points. But I'd like to draw your attention to the interquartile range between 6 and 21 points, and a range a minimum that was somewhat negative, and a maximum of a very large value of 61 percentage points. Well, what does this mean? For this one strategy where we have a lot of studies, in a quarter of the studies, the effect sizes were actually quite small. And in a quarter of the studies, the effects were quite large. And these results demonstrate the difficulty in predicting an intervention's effect in a new context, and underscores the importance of monitoring the effect of any intervention. Okay, let's talk about some specific interventions. So printed information or job aids for health workers. Programs do this all the time. Median effect size, 1 percentage point. Information and communication technology for health workers as a sole intervention. For example, sending text message reminders to health workers' phones. Median effect size, 1 percentage point. Now, my team was a little bit surprised by this, given kind of what everyone's saying about health and digital assistants and whatnot. And we realized there were just 4 studies on this, so not that much. So we thought, what if we broaden the intervention definition to look at ICT by itself, or in combination with other intervention components like training, supervision, whatever. And the goal, which is shown on the bottom of this slide, is to analyze a larger pool of studies with a greater diversity of context and implementation approaches. So we did this, and we found a total of 28 studies. So the original 4 plus 24 studies of ICT combined with something else. And we thought, all right, well, we have pretty much everything on ICT. The median effect size was 8 percentage points. So a lot of heterogeneity, but in general, the effectiveness just was not all that great. Training only, as I mentioned before, the median effect size is 10 percentage points. Now, there were a lot of studies on training, and so we thought, well, let's see if we can learn a little bit more. Especially, can we understand that heterogeneity a little bit better? And so we asked, ourselves, well, are some training approaches more effective than others? And so these results were published earlier this year in BMJ Global Health. You can see the article there with a link. And we found that training tended to be more effective when it was at least partly conducted in health workers' routine worksite and when it used clinical practice as an educational modality. With supervision, the median effect size was 10 percentage points. And similarly, we asked the question, are some supervision approaches more effective than others? These results haven't yet been published, but we found in general, supervision tended to be more effective when supervisors themselves received supervision and when they participated in group process activities like group problem solving during their supervisory visits. Now, neither of these results is statistically significant. I want to point that out, but these were the signals we found in the data. There were much fewer studies of supervision, so we didn't really have quite the same sample size compared to the training analysis. The combination of training and supervision, 18 percentage points. And then moving on to group problem solving. So for example, continuous quality improvement or collaborative improvement. There's some photographs of the latter at the bottom. The median effect size was quite a bit larger at 28 percentage points. But there weren't that many studies of this. And we thought, well, all right, what if we broadened the definition again to look at group problem solving by itself or in combination with something else? And you can see the result in parentheses of 12 percentage points. And my co-investigators and I feel that this lower, more conservative estimate might be more typical of what you would get in the field because it's based on a kind of a larger pool of studies, again, from a greater variety of contexts. We then found some studies where group problem solving was combined with training as a package. And the median effect here was quite large at 56 percentage points. When we broadened the definition, it dropped quite a bit down to 16 points. Now, I want to focus on collaborative improvement for a moment. This is a type of group problem solving. And here, quality improvement teams in a network of facilities are testing changes in the processes of care that they deliver using plan, do, study, act cycles. And this is something that's been of interest, I think, in the quality of care community. And so that led to a spinoff review with some colleagues in Argentina, and that was published in 2019. And the particular point I want to mention is that when we looked at the combination of collaborative improvement combined with training, the median effect size was quite large at 63 percentage points. We next identified a more complex, multifaceted strategy. So here it involved strengthened supervision. In this, an example would be the provision of medicines or equipment, plus supervision, plus what we call other management techniques, which in this case was health worker group processes or meetings, plus training, all together as a package. And the median effect size here was 33 percentage points. And even when we broadened the definition to include this package plus other things, the effect size didn't really change very much. And then we found this same package, but there was an added component of either a financing component or some other kind of incentive. And an example might be a performance-based non-financial incentives. Just to remember, not all incentives, involve money. In this case, it was done in the private sector, so an identification badge was given and an advertising sign for the shop after the health workers passed a test. And the median effect size of this combination was very large at 58 percentage points. When we broadened the definition to look at this combined with other things, it dropped to 33 points, but that's still actually a fairly respectable effect size. So after we looked at these latter results, we started to ask ourselves, well, is it that multifaceted interventions are fundamentally more effective than simpler ones? Well, we could use our data set to address this question quantitatively. So here the x-axis is the number of intervention components and the y-axis is the effect size. So the box plot that you see on the left shows the distribution of effect sizes for any strategy as long as it had a single component, training only, printed information only, whatever. So as we add more intervention components, does the effectiveness increase? And the answer is no. So what this is telling us is that even though there's some specific multifaceted strategies that are quite effective, in general, just by adding more intervention components doesn't improve effectiveness. In other words, for every one multifaceted strategy that was highly effective, there were probably quite a few that were relatively ineffective. Okay, moving on to interventions to improve the performance of lay or community health workers, clearly a very important cadre. So there was a lot less to say. There were just 18 studies, most with high or very high risk of bias. These studies tested 14 interventions, most of which were tested by just 1 or 2 studies each. We found that for training community health workers as a sole intervention, there were 4 studies of that, the median effect size was just 2 percentage points, so really no meaningful effect at all. We did a little bit more digging and found that for interventions that included some kind of community support activity like community education plus training for the community health workers, the effects were larger, ranging between 8 and 56 percentage points. But this was kind of a hodgepodge of different strategies, and so the evidence base is really quite thin. Okay, well, that was kind of a lot of results, a lot of numbers. Let me see if I can pull this together and present some evidence-based guidance on improving health worker practices. Okay, some general guidance. First, the effectiveness of any intervention should be monitored so managers can know how well it's working. This is important for adaptation and learning. What's a general approach to get started? So select that initial intervention based on research evidence and knowledge of the local context, monitor health worker practices, that's getting back to the first point, and addressing quality gaps, which really should be expected, and then continue to monitor and modify as needed. And then finally, decision makers should not assume that multifaceted interventions are going to be more effective than simpler ones. Okay, regarding guidance for professional health workers, printed information or job aids to health workers as a sole intervention is unlikely to change performance. Programs do this all the time, but the evidence suggests that they won't have much effect by themselves. ICT typically has small to modest effects. Now, I don't mean to sound, anti-tech or anything, but I think the message here is that if someone comes up to you and says, "Oh, I have a new app, I have a new device that's going to, revolutionize quality of care," please ask for the evidence first. Third, training or supervision by themselves tend to have moderate effects, and it may be more effective to combine training with other interventions such as supervision or group problem solving. To increase the effect of training, it may be beneficial to conduct part of that training on site and to include clinical practice. And to increase the effect of supervision, it may be beneficial to supervise the supervisors and have the supervisors engage in problem solving during their visits. Group problem solving by itself typically has moderate effects. And then certain interventions tend to have larger effects. So the specific multifaceted interventions that we discussed earlier, as well as group problem solving plus training. But I think especially the combination of collaborative improvement plus training. For community health workers, only training CHWs typically has very low, small effects, and interventions that include some kind of community support activity plus the training for the CHWs might lead to larger improvements, but the evidence is really limited. Speaking of limitations, here are 2 big ones. So the first is the limitations of the studies. There was often a lack of detail on the intervention and context, certainly not a lack of standardized methods, difficulty in assessing study precision and strength of implementation. There was often a high risk of bias and short follow-up time, and studies often were on a small scale. A second limitation is kind of this overview analysis approach that I've been using, which really involves a lot of lumping of categories. And it was intentional. And the idea was to identify broad patterns across all the studies, really take advantage of the sample size. But the results don't reflect some important nuances. For example, all countries are combined. So the solution for this is to conduct context and content-specific analyses with the publicly available databases of the systematic review, the Healthcare Provider Performance Review, which is a clever way for me to segue into a very brief demo of the website. So www.hcpperformancereview.org at the top. So there are a few tabs. It's a fairly simple website. There's a tab with video tutorials, or just one actually, a place where you can get our publications, a place where you can download some relatively simple Excel spreadsheets if you wanted to do your own analyses. And then on the home page, there's this online analysis tool that I really want to talk about for just 1 minute. So it's a very simple process. You use a series of menus, just point and click menus to select the subset of studies that you're interested in. And you can see those menus at the bottom of the screen. And then you just click on the Run Analysis button. So as an example, so I come from the Global Fund. So here's a question. What's the effectiveness of interventions to improve quality of care for HIV, TB, and malaria in Africa? So I'd go to the geography menu and click on the WHO Africa region. You can click on multiple regions or individual countries, whatever you like. So that's on the left. On the right, I've selected the health conditions, HIV, malaria, and tuberculosis. And on the bottom, I've clicked on the Run Analysis button. And I won't go through these results in detail, but just very briefly, on the left, you can see the strategies. In the middle, you can see the number of studies to give you a sense of how much evidence there is. And on the right is a summary of the effect sizes. A quick word on global reports and guidance. So there have been a number of important global reports that were published over the last few years. And so I won't go through them in any detail, but I think they're useful references. And also on the right side, WHO has recently produced a number of, I think, really important guidance documents. And so I recommend those to you as well. So in conclusion, inadequate healthcare quality is a large problem, yes, but solutions do exist. Second, the research itself has important limitations, yes, but I think the results are useful to inform decision-making. Third, some interventions genuinely do seem more effective than others, and we should consider using them in the appropriate context. Fourth, there seem to be ways of making training and supervision more effective. Fifth, we should probably avoid ineffective interventions. Sixth, it's important to monitor the effectiveness of all interventions. And I really want to emphasize the need for more measurement of quality of care, because without data, it's really hard to know what's going on and whether what you've done has made a difference. Seventh, we should consider taking broader actions for improving quality. And again, I refer to those global reports. 8, high quality research is still needed, for example, on community health workers. And then finally, I think the Healthcare Provider Performance Reviews website can be a way to find evidence that's tailored to your particular geography, health condition, or service delivery context. And I'll stop there. Thank you so much for the opportunity. Over.
Thank you so much, Alex. So I think we're going to do the questions at the end. So everybody, please keep adding your questions in the chat. I see they keep coming, and we'll pass it straight on to Owen.
Just a quick check if you can see my slides.
Yes, we can.
Yes, thank you so much. And thank you once again for this opportunity. I'll take your presentation, lessons from a review of performance, a review of programs and Malawi country experience. As you can see, Malawi is one of the countries in the sub-Saharan Africa, bordering countries like Zambia, Mozambique, and Tanzania. And I'm going to introduce you the Quality Management Directorate, which was established in 2016 to provide strategic leadership and also coordination of quality management initiatives across the health sector in Malawi. And the directorate has 3 divisions. One is to do with norms and standards. The other division is quality assurance. And the third one is a division to champion quality improvement initiatives. And that's the division where I come from. Now, Quality Management Directorate has a policy, and I'm going to show you the key priority areas for quality of care in the health sector. One of them being leadership and governance, including accountability. We want that our facilities should be managed with leaders that are capable and they know quality improvement initiatives. And also we have strong structures, governance structures that are able to be accountable to the decisions that they make. We are also looking at the human resource because it's another challenging area in the country. Human resource for health has been a very critical and challenging area for some time now. So this is another area that as QMD, we are also looking at to improve in our facilities, working together with other directorates. Another area of priority is clinical practice, making sure that all key policies and guidelines to guide clinical practice are updated, and also that clinicians and nurses are using them appropriately. Client safety is another area that as QMD we put as a priority, and we want to make sure that our facilities are safe, our clients are safe, and also including the healthcare workers. Our care should be people-centered, in the sense that we should not look at our patients as statistics or as diseases, but also we should look at holistic approach of managing our patients or clients. We also look at support systems, including technologies that is going to support delivery of quality care. And lastly, we think that it's time to make sure that our healthcare workers are able to utilize the evidence that we get for decision making. It's an area of it's a problematic area to make sure that facilities or healthcare workers are able to utilize the information that they get, the data that they generate. They should be able to analyze and produce information that they're going to use for decision making. It's an area that we're also interested in, and we're working with our facilities to make sure that this is done. The directorate is pretty new, as I mentioned, established in 2016, and we've been working hard to make sure that we have policies in place, including strategic document to guide our work. And these are some of the documents that we managed to come up with. The National Quality Management Policy. We also have the strategy, including the quality of care roadmap, implementation guides. We managed to adapt a number of standards from WHO, the MNH standards, pediatric standards that we adapted from WHO. And also we have a training manual for quality improvement, and also a mentorship, a mentorship guide, a mentorship manual. Malawi as a country joined other countries in the global network for quality of care network in 2016. This was also time when the Quality Management Directorate was being established, but we have moved moved greatly, and we are indeed using MNCH, that's maternal, newborn, and child health, integrated as a pathfinder for quality of care in Malawi, and its implementation is using the strategy called LALA. I think Martin mentioned about the LALA strategy, and that's the platform that we are using. We also have what we call the quality improvement model for Malawi, and this is the model that we are championing to close the gap between the current situation and the situation in which we are expecting, or the desired goal. So we are using what we call the improvement model for Malawi. It takes into consideration, or it's a harmonization of a number of quality improvement model that some of us in the forum were familiar with. We do 5S activities. 5S is, these are Japanese, it's adapted from Japanese model. So we have 5S activities. The aim behind is to make sure that these activities help us to improve our work improvement, our work environment. So providers or healthcare workers do these activities to make sure that the environment in which they work in is quite safe for them as providers and also for their clients. We also are doing a lot of CQI, continuous quality improvement activities, to improve services. And this is really oriented to our clients. And by the end of the day, we would want to achieve total quality improvement or total quality management, where all departments or all service departments are oriented into quality improvement initiatives. So we develop a culture of quality in all our facilities, so that by the end of the day, we achieve quality in our healthcare services. This one I've already mentioned. Just to go quickly, that we have a quality improvement training manual, championing the quality improvement model for Malawi. We have training materials in place. We currently have 9 improvement advisors at QMD that were trained through IHI. And all the districts that we have, they have trainers in place. We have managed to establish some structures at this level, the quality improvement support teams, and also work improvement teams in the facilities, both at Central Hospital and district hospitals. And currently, most of them are running quality improvement projects at various degrees of competencies. So we have a number of partners that are also supporting us in this agenda. So I wouldn't want to bother you much with this slide, but just to say that the quality improvement support team is a multidisciplinary team involving all departments at a hospital. And also the work improvement team comprises of people that work in that particular department. So just in brief. We have done a number of capacity building to make sure that we have teams in the districts to support quality improvement initiatives. And the pictures you see there is one of the trainings that we conducted with district teams to make sure that we developed a pool of trainers and also a pool of mentors. So you can see team members discussing quality improvement. During this period of COVID, we also had a virtual training, which was supported by WHO, UNICEF, and it was a 4-day training. We targeted 80 participants, but due to other challenges, we managed to train close to 60 participants. And some of the challenges were due to network challenges to participate in virtual training. Otherwise, it was one of the successful virtual training that we had in quality improvement. We also do a lot of collaborative meetings just to make sure that districts are able to share experiences from the quality improvement activities that you see that they are doing in their facilities. And this is one of the collaborative learning session, one of them that we had. And most of the facilities were showcasing progress in their QI projects, especially targeting standard 1 and standard 9 in the that they are doing. So after this, we also do a bit of teaching in QI2s, because after this collaborative learning lesson, we identify gaps in their projects, and we conduct some training, especially on the QI2s. So just to show some of the projects that they showcase during the collabos, just for example, there's this project looking at the percentage of asphyxiated babies born at one of the health centers from that period that they stated, and they try to put a number of quite change ideas. You can see from the first one, allocating maybe 4 nurses day shift and 2 night shift, and also doing CPD sessions. CPD is continuous professional development sessions. So they do all these change ideas to make sure that they see improvement. Another project is about adherence to hand washing, and you can see the progress that they're showcasing. Just some pictures to show evidence of these activities. Participants enjoying the QI project there, and also if, one of the members of the facility describing or explaining the run chart, interpreting the run chart, as you can see. So we also encourage the work improvement teams to teach each other, especially working on some of these diagram like the Pareto chart, as you can see, a WIT or work improvement team trying to help one another to plot a Pareto chart. Another activity that we do is supportive supervision, trying to visit these learning facilities to check their performance. And then after that, we also provide feedback. This is one of the learning sites that we visited. This is Zimba District Hospital. We are doing a supervision on 5S activities. And this is very crucial for performance improvement, because you identify gaps and you discuss on the gaps, and at the same time you try to develop some action plan, quite improvement action plan. Yeah, some supportive supervision and also feedback at the same time. They indeed boost some morale, especially when you give positive feedback, and also try to mentor them on the shortfalls. Another area that we have noticed is that we really need to find a way of recognizing best performance. Our providers would like to be recognized. So this is one of the recognition, is giving certificates after completion of a practical training, but also there are many more that we can do, recognizing individuals and also recognizing teams. So it's an area that we need to do more, so that our teams are recognized and they are happy and they are motivated. There's one area that as a country we're not doing well, is doing performance management system in the civil service. There's a performance system that was introduced in 2008, but up to now, this system is not yet institutionalized in the public service. The major reason that we have noted is that sincerely, there's no linkage between rewards and performance, and usually workers don't see the reason for doing performance appraisals. So this is an area that really requires serious reforms, and it's an area the country is working on. Otherwise, we still have challenges that we need to work on as Malawi, as we drive quite improvement. We have noticed that work improvement teams at department level are not adequately trained. So it's an area that we still need to work on to make sure that we give them the necessary capacities to drive improvement. Otherwise, we also hit hard in terms of turnover of staff. And as you continue to do capacity building, you find other members are moving out. So you start all over again. So this is another challenge that we have to work on or continue to train more. We also see less interest from senior doctors or clinicians, and most of the participants that we see are nurses and junior staff. And this is an area that we need to work hard, that senior doctors need to be interested in quite improvement activities. And that will also be a morale booster to other junior workers. We need to make sure that improvement projects are completed in time. We noticed that most of the improvement projects that the facilities are doing never finish at all. So it's an area that we are still working on. Others are mentioning because of COVID pandemic, and I disrupted most of their focus. And indeed, we understood that COVID-19 indeed disrupted, and it continues to disrupt some of our quite improvement activities. So there's also no standardized assessment for healthcare workers after QI training. So there's nothing much that I can share for now, but this is an area that we are working on to make sure that after QI trainings, we should have a way of assessing improvement in the performance of our healthcare worker, training healthcare. So we have also made a plan and to start a QI mentorship program. And this is going to be a 6-month QI mentorship program with a name of improving skills in facilitating QI in the 9 learning districts. And also it will help us to build a pool of district mentors. We want to have at least 12 mentors per district. And this will help us to conduct mentorship coaching visits to the learning sites. We also need to make sure that we get successful QI projects in each district, which will be eligible for spread or for sharing with other facilities that are not doing the same. Otherwise, I would like to acknowledge various partners that support us, WHO, UNICEF, Africa CDC, and these other partners that you can see on the slide. Otherwise, this seems to be my last slide, and I thank you all for your attention. Thank you.
Thank you so very much, Owen and Alex. This was really interesting. I'd like to invite the two of you to turn on your screen so that we can see you for the question and answer. And we will jump right in. We have about 10 minutes. So I'm going to start with a question for Alex. There's a question on the difference that you might have seen, or if you looked at differences in effects in low versus middle income countries, given that there are massive difference, obviously, in infrastructure and capacity. And did you look at that at all?
Yes, that's a good question. And we did. Let's see. So what we did was, I'm just flipping through some notes. What we did was we looked for strategies that had at least 3 studies in each of those 2 categories. And we found that there were a number of strategies where there was really no difference in effectiveness between those 2 categories, and then a few that did. They're not. It's not jumping out at me right here, but I can tell you from memory. So, for example, group problem solving tended to be more effective in middle income countries compared to low income countries, as did I think the combination of training and supervision. Training by itself is an example of something where there was no obvious difference between the 2. I can continue to hunt through my notes. If Owen has the next question, I can tell you even in more detail later. But the short answer is a few strategies did, a few strategies didn't have differences. Most strategies had so few studies that it was impossible to tell. Over.
Great, thanks a lot, Alex. And I will jump in for the next question. And just to say that, thank you very much for everyone for posting questions. There's been a lot of great, but we will try to pick some. So I have one for you, Owen. Can you please say a bit more about how the QMD works with other directorates in the Ministry of Health, particularly the HRH and the RMNCH on quality, how they work together on quality issues? And in other words, how is the Ministry of Health combining building a system for quality with decisions on HRH allocations and improvements on implementation of MSH technical standards?
Yeah, thank you so much. Let me respond to the question that how do we work with other directorates? You might be aware that quality management or quality is cross-cutting issue. We have made sure that we have a focal person, quite a focal person in each and every directorate. And preferably what we have done is that to make sure that a deputy director in each directorate is part of the quality management forum. So we have focal persons, and we have a forum for focal persons for all directorates. So we are able to meet and share activities that are happening in each and every directorate. And also we are all part of the quality management technical working group. So all the initiatives that are happening in each and every directorate are also presented at TWG, and also during our meetings as focal persons, we are able to update each other and see what improvements can be made, especially in the HRH and also other directorates like clinical services, nursing services, just like that. To the other question, that one is a bit tough, but I'm lucky I have my director in the forum. If he's comfortable, I think he can also take that other bit of the question. Over, Martin.
You, Owen, and I think you responded well. So maybe let's see if the director will do. But in the meantime, I'll see if Anne if you have identified any other question.
Yeah, so I'm going back to Alex, and there's a question on how studies of performance of health workers, and particularly those that look at interventions, account for and control for the enormous variation that there is in workloads, access to resources and equipment, staffing and wages, etc.
Yeah, that's a really great question. So yeah, so in a sense, like what's the background context in which these interventions are tested? And there was, so my team, the data abstractors, we really tried to get at this, but there really tends to be fairly poor description of the context. And if there is a description, one study might focus on one aspect of the context and another study will look at something else, something that makes sense for that individual study. But for, systematic reviewers like me, I'd like to have something standardized so that I can kind of stratify on that or kind of somehow analyze it that way. So the most honest answer is the information just really isn't there. And in fact, one important recommendation coming from the systematic review, which relates to how this research can be done better in the future, is to have a more complete and more standardized way of describing context. But that being said, there were definitely a lot of studies where either they made sure that there were adequate supplies of equipment or medicines, because I think the investigators didn't want that to be a confounding factor, because obviously it's hard to provide care if you don't have the basics. And there were some studies where adding resources, for example, specifically providing medicines or test kits or something like that was actually part of the intervention. So different studies kind of handle it in different ways. Over.
Excellent. Thanks a lot, Alex. So then I'll jump back to Owen for another question. It's quite straightforward. So Owen, from your experience in Malawi, how do you drive staff engagement in quality improvements?
Yes, that's an interesting one. Quality improvement could be something seen to be new in Malawi, but the most important thing is to make sure that the leadership of the facilities should be the first target to understand quality improvement. If you try to infect these people with quality improvement tools and how quality improvement is going to help them solve the problem that they have or that they see, it becomes a good starting point. So leadership, if you manage to win leadership commitment, it's much easier to move with others in the facilities. So we have managed to make sure that all district leaders, like the directors of health and social services, the district medical officers, the nursing officers, are trained in quality improvement. They understand the tools to use in order to solve the problem that they have. So now they start enjoying quality improvement, and it becomes much easier to infect the other junior staff way down the line. So I would say that the key is to make sure that the leaders understand quality improvement and how it can help them resolve most of the challenges that they have. Over.
Thank you so much, Owen. I'm going to ask one last question to Alex. And we had really many very interesting questions. And we hope that our two speakers are willing to respond to those offline, and then we will share them together with the materials from the webinar. So Alex, if you can give a short answer, but there is a question on whether there's evidence that training on quality of care itself is really helpful, or on quality of care interventions combined with either recognitions or with disease or program specific capacity building interventions might be more beneficial or impactful.
Great, thank you. So I think that I mentioned very briefly, there was a publication earlier this year, maybe that could be shared, that really dug into the training literature. And we actually analyzed 199 studies that looked at training either by itself or in combination with something else. And I think there were a few takeaway messages. The first is that kind of training by itself, especially the classic in-service hotel-based training, it just has a very small effect size, maybe about 7 percentage points. And when you look at the subset of studies that are of the highest quality, like the randomized controlled trials and well-done interrupted time series, it drops to about 5 percentage points. So in a sense, when you think about baseline performance level, training is kind of like a vaccine with like a 12% efficacy. So yeah, training by itself, probably not the way to go most of the time. However, when training is combined with something else, something interesting happens, which is we found, and this is through a modeling exercise, that no matter what your intervention is, if you add training as a component, that strategy will be about 6 or 7 percentage points more effective. So it does have a role, but I would encourage, kind of programs and others to always think about training in combination with something else and be just very thoughtful about that. And then when training is justified, the 2 points that I mentioned during my presentation, I think are warranted. One is to try to do at least some of it on site, and also to use clinical practice as one of the educational modalities. So it's not just sort of, kind of sitting in a lecture hall. Over.
Excellent. Thank you very much, Alex. And I think we're right on time, 3 p.m. So I'll hand over just for some closing remarks, I'll guess. So if Patty or Sita would like to do that, please.
Yeah, I think Anna was going to do, but thank you very much for having participated with us. We are, as always, very glad to have the coordination and the collaboration with the Quality of Care Network. I think this was a very, very informative webinar, and we hope that we can provide the responses to your questions when we send in the Child Health Task Force. Sita, could you tell them where they can find it?
Yes, and we'll send the materials over email and then also post it on the Child Health Task Force website. Thank you all so much for coming.
Thank you.
Thank you, everyone.